So I don't want to bombard you guys with slides, but I just wanted to kind of take you through some things we might want to answer tonight or think about, and that's basically, is hip or knee replacement right for you? I see some folks who've already made that decision a while back, but we can still talk about it anyways. I'm going to talk about some newer techniques. When I say newer, it doesn't mean they were invented or brought out last week, but they've been around the last few years, maybe even the last decade, and there's more and more evidence that these techniques might make this surgery even better. And then maybe what are the future things down the road that we might expect for hip and knee replacement. This is not what we're going to talk about or try to answer, so anybody who wants to talk about that, we probably won't get to that tonight. Probably for the best. So my philosophy as an orthopedic hip and knee surgeon is I never want to be the first or the last doctor to adopt the latest medical technologies. And you may say, well, why do you want to be behind the times? Why don't you stay up and do the most latest and greatest things? Except that we all know that there's things in medicine, and especially orthopedics, that sound great, and then a few years later we're seeing the commercials on TV about call your lawyer, get this hip ripped out as soon as you can, or you're going to be in trouble. So things in surgery, especially orthopedics, take time and good studies to validate that it's not just something hot off the press that sounds good, because that's the last thing you want to do, is have something that sounds good and then find out a few years later it wasn't so good. So basically tonight what I want to stress is hip and knee surgery. Obviously we're going to talk about custom partial knee replacements and custom full knee replacements, and also what's called anterior total hip replacements. So those are the topics. So starting with basics, knee arthritis is probably why most people would get a knee replacement. And arthritis means that the cartilage is worn out such that the two bones, the femur and the tibia, or the kneecap and the femur, are rubbing together, causing pain, swelling, stiffness, and inability to do the things that you want without significant pain. So a really basic question that I get asked a lot in the office is, how do I know if I need surgery? Or how do I know when I need a knee replacement? Or how do I know when I need a hip replacement? Seems like a basic question, but it's actually pretty tough to answer, and I a lot of times leave it up to the patient. Most patients know when it's time. They're sick and tired of seeing me, sick and tired of getting a shot, sick and tired of limping in here every 3 months, and they just say enough is enough. But some general guidelines: if the pain is interfering with things you like to do, walking around the block, walking your dog, playing 9 holes of golf, and you just can't do it anymore without pain medicine, you're becoming less active, interferes with sleep. Basically, we try things that are simpler. We try shots and physical therapy and braces. If all of that has failed, then the next step may be a joint replacement. And again, not all pain is related to the joint. Some pain is soft tissue, tendonitis, bursitis, or coming from some other area. So we have to make sure with x-rays and other scans sometimes that a joint replacement is what's best for you. For knees, the 3 treatments that basically we look at are arthroscopy, which is scoping or cleaning out the knee, a partial knee replacement, or a total or full knee replacement. We're not going to talk much about arthroscopy tonight. It doesn't really have much of a role in severe arthritis, so we're going to skip over that and talk about the other things. And the first thing I'm going to talk about is partial knee replacement. Not everybody knows what a partial knee replacement is, but it's exactly what it sounds like. We replace part of the knee, not the full knee, but part of the knee. So that sounds kind of crazy, right? Why don't you just replace the whole knee instead of replacing part of it? Well, the reason is it can actually do better than a full knee replacement in some people, meaning it's less surgery, less invasive, and 2/3 of the knee is your own, so it's going to feel better than a knee that's totally artificial. So why wouldn't you have a partial knee replacement? Some data shows these may wear out quicker than a full knee replacement, so we have to change it down the road to a full knee replacement. Not all the time, but sometimes. And then sometimes arthritis can come into the knee down the road, and we have to change it to a full knee. So the people that I recommend this for are usually higher activity people, usually younger age, and they have to have realistic expectations that this may not last them a lifetime. But these are folks that want to run, want to do pretty intense sports, and they're willing to possibly undergo another operation down the road. So this is basically a slide of what a partial knee is. We're basically putting metal and plastic in the part of the knee that's worn out. And in this slide you can see the metal is what we replace, the rest of the knee is what we leave alone. And one of the things that has come along recently is what's called a custom partial knee replacement, where we actually design a partial knee replacement just for you, where a CT scan is performed of your bone and an implant is made just for you. So it's a very personalized implant. It won't fit anybody else, but just you. So why do you need this? Everybody's bones are different sizes and shapes, and we, in general, traditional replacements, we have 10 or 12 sizes. This is the exact size just for you. And this is the tray that it comes in. It's manufactured in Boston. It takes about 6 weeks, and it comes in a tray like you see on the left. Very simple, very straightforward, not a lot of clutter, and very straightforward. So in general, this is not, I'd say probably 5% of the knee replacements I do are partial knee replacements. There's just not a lot of people, unfortunately, who have arthritis just in one area. So I don't know how many, this is real relevant to some of you, hopefully it would be. But if you're a good candidate, it's a good option. It's less invasive, quicker recovery. And in the future, we can convert it to a total knee. Hopefully we wouldn't have to, but we could. So I want to spend, this is more probably relevant to most of the audience. This is called custom total knee replacement, which is a newer concept in the last 5 years or so. You'll see some of these banners here of the company that makes this. This is a knee that's made specifically for each person. So there's no sizing abnormalities. If you're a woman, if you're a small woman, a big woman, a small man, a big man, this makes the knee totally for you. So why would you need a custom knee replacement? Because obviously one size doesn't fit all. It's kind of tongue-in-cheek. It's not. I mean, our traditional knees fit well, but they don't fit sometimes don't fit perfectly. So a custom knee uses computer and robotic technology to do what's called 3D printing. You probably heard that and seen that in the news. It takes a CT scan we'll look at here in a minute and prints out actually a custom metal implant for your bone that fits perfectly on your bone once we cut it. One of the problems in knee replacement is that in a lot of studies, 10 to 15% of people with traditional knee replacements are not satisfied with their knee. Meaning they just maybe didn't meet their expectations, maybe they wanted to be more active than they should be, maybe it hurts a little more than they thought, maybe it's stiffer than they thought. So that's a pretty high number, 10 to 15%. So a lot of research has been done over the last years to determine how to get that number down. We'll see in hip replacement the number is low. It's probably less than 5% of people may be dissatisfied or not completely satisfied with their replacement. So 10 to 15%, sometimes in some studies it's as high as 20% of people are not completely satisfied. So the thought is, if we make an implant that specifically matches your own anatomy, recreates how your joint was before the arthritis, is that going to lead to a better outcome than an off-the-shelf implant that we try to make fit, and usually does fit well most of the time. So I don't know that we have that answer yet, but there's some early data to suggest that it does help this process. And basically a total knee replacement, again, the far left is a knee with arthritis. All the white stuff or the cartilage has been destroyed, so you're down to the red stuff, which is raw bone rubbing on bone, like 2 pieces of sandpaper. That creates pain, swelling, stiffness. That's the x-ray in the middle, and then the total knee replacement is the picture on the right, where we put 2 pieces of metal, and the small space in between is hard plastic, so that no longer are the 2 bony surfaces rubbing together. You have metal and plastic in there. So every patient that gets this gets a specialized CAT scan, which takes about 30 minutes, which maps your entire leg from hip down to ankle, specifically the knee, and generates an implant specifically, like the bottom picture, an implant specifically for your knee. So again, it takes into the account your anatomy and how it works backward from the knee that you have now to how your knee was before it was destroyed by arthritis. It then sends me this pretty, you don't have to read this pretty complex diagram that shows how much we need to take off, how much bone we need to take off of each side of the knee to recreate the natural anatomy. And it's actually very, very impressive how it does it. And then it sends us, just like the partial knee replacement, it sends us a tray of instruments with your new knee in it. And that comes 6 weeks after your CT scan. So why is that? So people looking at that array of instruments there might say, wow, that looks pretty complicated. But if you compare that to our traditional knee replacements, that's basically, we need 2 or 3 full tables of instruments, because you want to have every size available. We know kind of where you'd fall, but we want to have every size available of traditional knees. So that's a bit more sophisticated, and you can imagine it's easier for the entire team to perform that operation potentially than that operation. So here's how it would work. You'd come to the office. We would try everything short of surgery. Once we decide to schedule surgery, we would do the CAT scan, the CT scan. Approximately 6 weeks after the CAT scan, we would have everything made. It has to go to Boston, get made, and then get sent back here. Surgery is the surgery is about the same length as a traditional surgery. It lasts about an hour. Some of these we do outpatient. Some of them people stay a day. Some of them stay 2 days. Some people go straight home. Most people go straight home. Some people, depending on their needs and social situations, will have to go to a rehab facility after surgery. But that, again, that's a small number. In general, golf and other recreational activities is about 6 weeks. That's a kind of a picture of this. We use these all joint replacements. I just threw this in there. We use these spacesuits, which protect not only the surgeon but also the patient from any sort of germs or contamination. So the early results of custom knee replacements are encouraging. Again, we don't have a lot of data, but there's less blood loss because we're being less invasive, taking less bone. So in general, less blood loss, shorter hospital stay, and some of the early results show less pain. Is it going to solve the 15% that are maybe dissatisfied? We don't know yet, but it's hard to argue that a custom knee replacement is a bad thing, right? I mean, it'd be hard to argue that the more closely you replicate your own anatomy, that's going to be a drawback. So I buy into the concept. I'm not sure everybody needs it, but I can tell you from doing hundreds and hundreds of knee replacements every year, there are some people who just don't fit into the sizes that we have on the table. And you do your best, and it probably is very close, but this thing fits like a glove on everybody. So I think it's an encouraging concept, and there's more and more of these technologies on the horizon, actually for hip replacements as well. All right, so the next topic is hip replacement, a specific approach to hip replacement called the anterior approach to hip replacement. Some of you may have heard of this. It's become pretty popular in the last several years. I've been doing it now for about 6 years. Hip replacement, it's never hip to start with. Again, the same concept as knee replacement, as knee arthritis. What happens in hip arthritis, the hip is a ball and a socket joint. Hip, by the way, is a much simpler joint. It's basically a very simple ball and socket joint. The knee has much more ranges of motion and angular range of motion that make it much more difficult to construct and get a good result. So hip replacements tend to do much better now than knee replacements do. So when you get to bone on bone, that's when we discuss hip arthritis. Sometimes we'll go to do hip arthroscopy if it's not too bad, but for the purpose of this talk, we're going to just talk about hip replacement. So what a hip replacement is, the picture on the left, the bright white area is bone rubbing on bone. The picture on the right, you can see metal in there, a new socket, a new ball, and a new stem. Traditional hip replacement was done with the patient lying on their side, what's called a posterior approach, or through the back of the hip. Your incision would be on the side, but the surgeon would get into your hip through the back. Been used for years, years and years with excellent results. Still used quite a bit. So these are the outcomes of traditional hip replacement, which are hard to argue with. Easier than total knee. A lot of people fairly unaware of the artificial hip after a while. So in comparison to knees, hips, any of you have gone through both, can probably attest to the hip being a little easier. Most people are pretty satisfied with the hip. So why am I up here trying to change what's been a great operation? There's been some issues with the posterior or the traditional approach that we possibly could make better. We have to cut through muscle to get through the back of the hip, which leaves people with sometimes some temporary, even some permanent weakness in the hip. Some people will limp for a while. One of the biggest drawbacks of the traditional approach is dislocation, which means the ball pops out of the socket, which you don't obviously want to have happen. Nerve injury is, there's a big nerve called the sciatic nerve that runs right back in that area that sometimes can get bruised or damaged or even unfortunately cut, and that can be a catastrophic side effect of the surgery. So those are all rare. I don't want you to think that every posterior hip replacement has those problems. Those are less than 1% problems. But this is what a dislocation looks like. That's not what you want your new hip to look like. You want it to look like the patient's left hip and not the right. So dislocation for surgeons is a big consideration, and if you're a patient, and I can tell you that when a patient has dislocations, it's a devastating event for surgeon and patient alike. So this approach appealed to me a while back because it is less invasive. There is no muscle cut. It is faster recovery. And I'll show you another thing that I like is that we have X-ray equipment in the operating room during the surgery, so we can get your components aligned just the way we want, whereas a traditional approach would take the X-ray in the recovery room, and at that point you're kind of stuck with what you got. This is not a torture device. This is the special table that we have. We have one downstairs and two at the hospital. It's called a HANA table, and helps us do this surgery more efficiently. This is the actual patient on the bed, and it helps us maneuver the leg, bend the leg, and get this just the way we want. This is just a slide showing that there's a natural space between some of the muscles in the groin. The incision is about a 3 or 4 inch incision in the groin, and there's a natural space there where we can get to the hip without cutting any muscle. So literally we're not waiting for any muscle to heal in this approach, which is nice. Again, this is another advantage I like of this surgery is during surgery in real time we're checking where we're putting the components and able to adjust that as we go. So we can get your leg lengths. Some people's leg starts out a little bit shorter. We can get that. We can get that evened off with the other leg at this time a lot easier. These are some of the images we can print out during surgery, so we have an idea to make sure everything looks just how we want it as we put it in, and not figure that out later on. So again, the advantages as I see them are quicker recovery because we're not cutting any muscle, so the limp practically has gone away. I see people now, Mason can tell you, we see people back now in 2 weeks. Some of them have no cane, no walker, no nothing, they come walking in. So there's not nearly the limp that people used to have with the posterior approach. The risk of dislocation with the anterior approach is low. It's not zero, but it's very low, so that there's many of you who may have gone through hip replacement in the past know that you weren't supposed to bend over or touch your toes or sit in low seats or cross your legs. There's pretty much none of those restrictions with the anterior approach, which is very nice. And that's just saying more of what I just said. So this is the whole thing. Basically, we decide surgery. Surgery takes about an hour. Again, some of these we do outpatient, some of them you'll stay a night or two. Most people go straight home. You'll stay on a walker for about 2 or 3 days, a cane for a week or two, and then most people are off of all canes in the first month. And then golf and all that is 6 weeks. So the last thing I want to touch on quickly is outpatient total joint surgery. Some of you may have heard of this recently, and it's not a joke. We do this. It's not for everybody. And right now, somebody was asking about Medicare. Medicare has not approved total joints for outpatients, so they're supposed to approve it starting next year. But as of right now, if you have Medicare, you can't have an outpatient total joint. But just a quick thing as to why I would want to do this. It's a good option for some patients. It's not for everybody, but those who are younger, more active, a lot of people who just can't stand being in the hospital. And any of you have been there know that you're constantly being woken up. The food is not the best. It's just not a place where you feel rested after surgery. So there's possibly some less risk of infection. Definitely in a surgery center like we have downstairs, we don't have the major resistant infections that some people have at the hospital. We can do newer pain management techniques with pain catheters where you go home and you have very little pain. And then cost-wise, obviously, if you're paying, you have an insurance program with large deductibles, this can be a better option for you. So this is just a quick overview of our data downstairs. We've been doing this now for a year. We have 40 patients that we've done. You can see these are young folks. The average age is 59. We've had no infections. Got to knock on wood on all of these things. Readmission rates, meaning we had to transfer them to the hospital, 0. Most people go home within 4 hours of their surgery. Average pain score on post-op day 1. Anybody that's had a joint replacement will say the first day after surgery I felt great, but it's the next day that they have most of their pain. So these are scores on the following day of surgery. 2 out of 10, which is awesome. And then satisfaction scores of 100% are hard to beat. So it's not, I'm not trying to sell this on anybody, but I think somebody asked about the future. And I think this is going to be the future. When I look back, I've been doing this for 15 years. When I look back at procedures, ACL reconstructions, rotator cuff repairs, those are folks that used to stay in the hospital several days. Joint replacements, 2 weeks. Right now, you can't find an insurance company to pay for an inpatient rotator cuff or ACL reconstruction. So the whole thing is going to evolve, and last thing I want to do is get into politics, but you know that there's not enough money in the system going forward, and there's going to be ways going forward of doing surgeries more economically, safer, and most importantly, probably with better outcomes for patients outside of the hospital.